Hello, my name is Dr. Daniel Petrylak. I'm professor of medicine and urology at the Smilow Cancer Center, Yale University. And I had the good pleasure to present the data for the group, for the investigators of impact of exposure on outcomes with Enfortumab Vedotin in patients with locally advanced or metastatic urothelial carcinoma. As we know, Enfortumab Vedotin is a antibody drug conjugate that targets Nectin-4. It delivers MMAE, and it's hard to believe, over a 12-year period, we've gone from phase 1 to phase 2 to phase 3 with this drug. And the phase 2 EV201 led to the accelerated approval of Enfortumab Vedotin in patients who were treated with prior platinum therapy as well as prior checkpoint therapy. And then EV301 was the pivotal trial that led to the full approval of Enfortumab Vedotin in that patient group, and that compared Enfortumab Vedotin to standard line chemotherapy. It's important to note that the dosages that are approved in this setting are a little bit different than Enfortumab Pembro. It's 1.25 milligrams per kilogram for 3 out of 4 weeks. And that was used in the phase 1, phase 2, and phase 3 studies. And so what we did was a post hoc exploratory analysis evaluating the potential impact of EV dose intensity as well as the use of dose modifications and exposure on outcomes using data from these monotherapy trials. The important thing to note here is that there's a lot of questions from clinicians in the community. What should I do with EV in terms of toxicity? When should I dose reduce? And am I affecting the patient's outcome by doing so? And it's important also from the patient standpoint because the patients really do want to do well and they don't like having their doses reduced. And it does have some problems in terms of toxicity reporting. So this is our study schema. We took the 3 trials. EV101 was a phase 1 study, and that's the only study that had 3 different doses of Enfortumab, 0.75, 1.0, 1.25. EV201 was in previously treated patients with metastatic urothelial carcinoma who had a PD-L1 and a platinum-containing chemotherapy. Cohort 2 were those patients who were cisplatin ineligible and had previously received anti-PD-L1 therapy. And again, that used the standard dosage. And EV301 took monotherapy patients and compared that to chemotherapy in the same setting as EV201. So we did PK, multiple blood specimens in the first 2 cycles of treatment. And then we looked at time average exposure up to the event of interest using a population PK model. We looked at objective response in terms of exposure on the 3 studies separately. And we also looked at duration of response, progression-free survival, and overall survival in EV301 only. And the response analysis in EV101 also included cases that I mentioned before of less than 0.125 milligrams per kilogram. EV102 was a different group of patients from Japan. Those were only 17 patients overall, and that was included in this data analysis. As we know, the 4 different trials are well balanced in terms of different characteristics. The one thing I will point out is that EV101 only had 3/4 of patients having prior checkpoint therapy. That's because this trial was initiated around 2012, and this was well before the era or the FDA approval of checkpoints. And then EV201 cohort 2 had 1.1% of patients having platinum-based therapy. This was a patient who had neoadjuvant therapy and then progressed on to metastatic disease and was considered to be platinum ineligible. So otherwise, very well balanced in terms of characteristics. We know that I think the remarkable thing about this drug is the consistency that we've seen from phase 1 to phase 2 to phase 3. And the median survival, 12.4, 12.9 months, objective response rate, time to response, median duration of response, progression-free survival. These are all very, very similar in these 3 cohorts of patients. In terms of side effects, we do see treatment-related adverse events that require dose reduction. It's anywhere between 1/3 to about close to half of patients. We saw this in cohort 2 of EV201. And then discontinuation occurs in 12 to 16% of patients overall. We know that peripheral sensory neuropathy and rash, as well as hyperglycemia, are the side effects that we are particularly interested in terms of patient care, because these can be dose limiting and treatment limiting in these patients. So peripheral neuropathy was the most common reason that these patients had a dose reduction. That was in 7 to 17% of patients, as well as a dose discontinuation. So let's take some of the data from the individual trials and look and see where we can potentially understand some things in terms of overall response rate. So on the left, I've got a graph that graphs the starting dose of EV in EV-101 at 0.75, 1.0, and 1.25 milligrams per kilogram. As we see, there's clearly a dose-response relationship. You go from 21.4% response rate to 42.9% response rate in the recommended phase 2 dose and recommended dose of 1.25 milligrams per kilogram. When you start looking at the ADC concentration average over time with up to 2 cycles, you see that there's a clear dose-response relationship with the ADC, and that suggests that there's a threshold value for response in this situation. Now, on the next slide, what we've done is we've taken quartiles of EV dose in terms of in the first 2 cycles, and looked at these quartiles in terms of response. And again, we see the same pattern. EV-201, better response with the higher quartiles of exposure. 301, better response with the higher quartiles of drug exposure. And excuse me, 201 and 301, better response. It's very, very similar in response rates, and data is very, very consistent. So again, this is post hoc, but the average antibody drug concentration does seem to portend a better overall response. And that's within the first 2 cycles. There was a prescribed way of dose reducing for these studies. You started at 1.25 milligrams per kilogram. If you needed to dose reduce, you went to 1. And then if you needed the dose reduce again, you went to 0.75. You could be off treatment up to 8 weeks on these cycles and then restart treatment as well. As we see, about a third to a half of patients required some form of dose reduction, and the most severe form of dose reduction, 8.8 to 20% of patients overall. But again, you do require for most patients a dose reduction. So let's look at this in terms of the cycles that are administered. And this is data from EV-301. And each of these bars represents a cycle. So here you start with all patients entered on trial, 296. You go down to 1 at the end. This particular bar it's a little bit misleading because this one patient was still on 1.25 milligrams per kilogram. But as you move and look at the dose intensity or the dose reductions, excuse me, you see that still about half of patients are at full dose at cycle number 7. And then it starts becoming more prevalent as you move on. So you're seeing more frequent dose reductions as you go past cycle, as you go on. About half of patients at cycle 7 are still at full dose. Does this have any effect on the overall outcome? So this graph is a little complex. It's a swim lane plot, but it shows those patients who are responding in EV-201. So all these purple dots here are those patients who have a first radiographic response. And the blue lines represent full dose. The white lines represent dose interruption. And yellow is dose reduction down to 0.75 milligrams per kilogram. So you see that there are some patients with multiple dose interruptions, excuse me, and then dose reductions down to 0.75, who still maintain a clinical response. And we do see that these responses can be maintained despite the fact that these patients are off drugs for significant periods of time. So this is something that you should be thinking about in terms of your patients. If you have to dose reduce, you need to do so for toxicity. So let's talk about safety. In terms of the overall ADC average. We looked at this in relationship to different side effects. So the overall incidence of peripheral neuropathy greater than grade 2 or equal to grade 2 was 33.4%. And we start looking at quartiles of overall drug exposure. We start seeing that there is a trend towards the higher quartiles. The lower EDC exposure was associated with lower risk, as one would expect. Skin reactions, that had a fairly short time to onset. Hyperglycemia, the same thing, short time to onset of 0.6 months. Peripheral neuropathy, it's related to exposure. So 4.7 months was median time to onset. So one of the things that may confound the interpretation of this exposure safety analysis in terms of neuropathies, the earlier time to skin reactions and hyperglycemia, confounds the interpretation of overall safety analysis. And I think one of the things that was surprising to me, since we know that MMAE is the toxic component of this, this was not strongly correlated with the incidence of these adverse events. So let's look at this in terms of dose reduction and response. So again, these are the different quartiles of overall drug exposure. And we look at the dose reductions, which, as one would expect, are greater in the lower quartile. To 1.0, 52.7%, to 0.75, 21.6%. And the median time to the EV dose reduction was about 2.2 months. So we see that again, as one would expect, the dose intensity increases as we move up this particular curve. But looking here, the median duration of response it's pretty similar. So if you dose reduce, you're most likely not going to affect the duration of response. And when we compare these different quartiles of overexposure to chemotherapy, that relationship is still maintained of an overall improvement in progression-free survival as an improvement in median overall survival as well. So again, this is showing you that this still is better than chemotherapy, even at the lowest levels of drug exposure. So in conclusion, EV monotherapy at 1.25 milligrams per kilogram shows a consistent benefit and manageable safety profile across multiple trials in locally advanced or metastatic urothelial carcinoma. Higher EV dose intensity was generally associated with greater probability of response. Dose modifications, including dose reductions, were common across the trials, particularly in later cycles. The safety and efficacy of outcomes with EV monotherapy was achieved with the use of dose modifications. The recommended EV dose modifications assisting in managing AEs may allow the patient to remain on treatment. Patients continue to benefit from EV monotherapy in the setting of dose modifications to manage AEs, and EV monotherapy provided a PFS and OS benefit versus chemotherapy across exposure quartiles. So the most important thing, these studies have gone on now over almost probably about a 12-year period, and we want to thank the close to 1,000 patients who've participated in these studies, and particularly those individuals who have helped the research assistants, the nurses, the other doctors who participated in the design as well as in the implementation of these trials. Thank you.